Good morning, team. So this presentation explains why we write what we write to ensure that the clinical assessment performed by the nurse practitioner is thoroughly and accurately reflected in the medical record, with facility documentation and nurse practitioner progress notes working together as a single clinical record. MDS serves as a framework to help ensure the full clinical picture of the patient we assessed is clearly captured and supported. This presentation is about the documentation we write in the history of present illness and make sure it flows directly into the MDS capture and audit review. Our goal is not to change clinical practice, add work, or increase documentation volume. The goal is to ensure that what we document is accurate, defensible, and ethical, and that it clearly reflects the care we are actually providing. We will focus on how to document clinical context appropriately in the HPI and how to distinguish monitoring from medical decision-making, and when a diagnosis truly belongs in the assessment and plan. This framework supports skilled nursing documentation without inventing care, forcing plans, or documenting decisions that were not made. It aligns clinical judgment with CMS expectations and MDS logic. Throughout this presentation, the emphasis will be on clarity, honesty, and consistency so that our documentation can withstand audit review and, just as importantly, reflect care that we can stand behind professionally. These snippets are not about documenting more. They're about documenting more honestly. We are not adding diagnoses or interventions that aren't happening. The goal is to describe the patient's clinical context in the HPI, not to force plans that don't exist. If a diagnosis requires active management, it belongs in the assessment and plan. If it doesn't, it still may belong in the HPI, and that's okay. These snippets help us clearly justify skilled care without inventing treatment or monitoring. This protects patients, clinicians, and the organization in the case of a CMS audit. We are introducing new snippets to improve clarity, accuracy, and consistency in how we document HPI and monitoring only diagnosis. This is not about checking boxes, increasing reimbursement, or satisfying auditors at the expense of clinical truth. It's about making sure our documentation reflects what is actually happening with the patient. One of the biggest issues we see, and one that CMS frequently flags, is documentation that blurs the line between clinical context and medical decision-making. This often results in diagnoses being placed in the assessment and plan without any true plan, or vague monitoring language that doesn't reflect real care. These new snippets are designed to clearly explain why a diagnosis is relevant today, support skilled nursing presence when appropriate, avoid creating implied interventions that are not occurring, and you will notice that these snippets focus on current stability, what nursing is observing, not ordering. Avoid promises of preventing hospitalization unless critically or clinically appropriate. Importantly, not every diagnosis needs to appear in the assessment and plan at every visit. If no medical decision is made, no medical plan is required. These snippets allow us to document that reality clearly and defensibly is in the HPI and not under the assessment and plan. The end result should be documentation that is easier to write, easier to read, easier to defend, and most importantly, documentation we can stand behind ethically and clinically. This slide introduces an important boundary. Before we look at examples or detailed guidance, it's critical to understand that these snippets have a defined purpose and clear limits. The next slide will walk through exactly what these snippets are intended to do and what they're not intended to replace. The slide is really important because these snippets have boundaries. They live in the HPI. They are not plans and they are not orders. If you're making a medical decision, changing a medication, or ordering a test, that belongs in the assessment and plan. If you are simply explaining why a diagnosis still matters today and no decision is being made, that belongs in the HPI. These snippets are optional tools, not mandatory phrases. If a snippet doesn't fit the patient or the visit, don't use it. These are intentionally limited in scope. They're designed to support the history of present illness, not replace clinical judgment or medical decision making. The snippets provide clinical context, explaining a diagnosis, its current stability, and why it remains relevant to the visit, but they do not represent a medical plan. If a diagnosis requires active management, such as starting or stopping medication, ordering labs, or documenting a treatment decision, it must be addressed in the assessment and plan. Conversely, if no medical decision making is made, it is appropriate for that diagnosis to appear only in the HPI. These snippets help document that reality clearly and consistently is there without forcing unnecessary plans or interventions. These tools are optional and should be used thoughtfully. They are meant to support accurate documentation, not to replace individualized clinical reasoning. The distinction between the HPI and the assessment and plan is critical for accurate, defensible documentation. The history of present illness is intended to provide clinical context. It explains the patient's current status, relevant history, and why certain diagnoses still matter at the time of the visit. Stable conditions or diagnoses that require observation but no active medical decision making may appropriately live in the HPI alone. The assessment and plan, on the other hand, is reserved for active medical decision making. This includes starting, stopping, or continuing medications, ordering labs or diagnostic studies, making referrals, or documenting the rationale for a specific treatment decision. A common documentation error is forcing diagnoses into the assessment and plan when no decision has been made. This often leads to vague or inaccurate monitoring language that does not actually reflect the care and increases audit risk. If no medical decision is made for a diagnosis at a given visit, it is appropriate and often preferable for that diagnosis to appear only in the HPI. This approach supports clinical accuracy, reduces unnecessary documentation, and aligns with CMS expectations. This example demonstrates appropriate documentation of a history of CVA when no active medical decision-making related to the diagnosis occurs at the visit. The resident has a residual neurological and functional effects following a prior CVA. At today's visit, The resident is neurologically stable, and no decisions regarding anticoagulation, imaging, medication changes, or further stroke workup are made. Rather than forcing that CVA into the assessment and plan with vague monitoring language or implied interventions, the diagnosis is appropriately documented in the HPI as clinical context. The skilled nursing monitoring described here is observational, watching for changes in neurological or functional status, not decision-based. This approach accurately reflects the care being provided, supports skilled nursing presence, aligns with MDS logic, and avoids creating unnecessary or misleading plans in the assessment and plan. Importantly, this documentation does not represent under-documentation. It represents accurate documentation of a stable condition without active medical management. This slide clarifies one of the most common documentation errors, equating monitoring with medical decision-making. Monitoring refers to observation of a patient's clinical status, such as neurological function, respiratory status, GI symptoms, or cognitive stability, without initiating or modifying treatment. Monitoring alone does not represent a medical decision. Medical decision-making occurs when a provider actively evaluates options and makes a determination, such as starting or stopping medications, ordering diagnostic tests, making referrals, or documenting a rationale for treatment or no treatment. When no medical decision is made at a visit, it is inappropriate to force a diagnosis into the assessment and plan with generic or vague monitoring language. Doing so may misrepresent the care provided and increase audit risk. In these situations, documenting monitoring in the HPI is both accurate and appropriate. It explains why a diagnosis remains relevant without implying interventions that are not occurring. This distinction supports ethical documentation, reduces unnecessary charting, and aligns with CMS expectations. The assessment and plan is reserved for active medical decision-making. This includes any situation in which the provider evaluates options and determines a course of action. Whether that action is to initiate treatment, adjust therapy, order diagnostic testing, or document the rationale for not treating. A diagnosis belongs in the assessment and plan when it directly informs what the provider decided to do or not to do during the visit. Again, this may include medication management, diagnostic evaluation, referrals, or risk-benefit discussions. Importantly, documenting a reason not to treat a condition is still medical decision-making, and it should be captured in the assessment and plan. This slide is not meant to encourage over-documentation, but rather accurate placement of documentation. When a diagnosis requires no active decision-making at a visit, it may be appropriate to stay in the HPI alone. When a decision is made, the assessment and plan is the correct place to document. This distinction supports clinical clarity, audit defensibility, and ethical documentation. This slide demonstrates how documentation can change significantly without changing the patient or the care provided. In the before example, CVA is listed in the assessment and plan, despite no CVA-related medical decision being made. The plan includes vague monitoring language and deferred decision-making regarding anticoagulation, which may misrepresent care and increase an audit risk. In the after example, CVA is documented in the HPI as clinical context. The patient's stability and residual effects are clearly described, and skilled nursing monitoring is justified without implying treatment decisions that are not occurring. Importantly, nothing has been removed from the care being provided. Only the placement and framing of the documentation has changed. This approach improves clarity, supports nursing presence, aligns with CMS expectations, and avoids unnecessary or inaccurate assessment and plan entries. This slide provides an overview of just a few snippets that have already been created, as well as those that are still in development. The examples shown are not intended to represent a complete or exhaustive list of diagnoses. Can you even imagine how many diagnoses we have? They reflect common conditions encountered in SNF practice and were prioritized to address areas where documentation has historically been inconsistent or audit sensitive. Importantly, this system is designed to be flexible and responsive to clinical needs. Nurse practitioners are encouraged to request additional diagnosis-specific snippets when they identify gaps or recurrent documentation challenges. Send those requests to me, and I will create a snippet for you. Requests should be submitted to me. They'll be reviewed, developed using the same framework discussed in this presentation, ensuring consistency, accuracy, and alignment with MDS and CMS expectations. The intent is not to limit clinical judgment or force templated language, but to provide optional tools that support honest, defensible documentation. So the first one that I see up here is metabolic encephalopathy. So these are the patients that come from the hospital. They've got that diagnosis in there, but we're not medically treating them. Does that mean their cause of hospitalization, which was the metabolic encephalopathy, is no longer relevant or not an active diagnosis any longer? No. What it means is that we're not medically treating the patient. The diagnosis is still valid. It's still something that needs to be closely monitored. So here is our statement. It's a snippet in TrueRCM. It says the resident has a history of metabolic encephalopathy superimposed on underlying cognitive impairment. Now, it doesn't verify Alzheimer's, dementia, or cognitive impairment. It just says underlying cognitive impairment and is clinically stable. So we've got a stable patient here. Ongoing skilled nursing monitoring is required to observe for changes in mental status or level of alertness that may indicate recurrent encephalopathy or medical decline. Now, because skilled nursing is monitoring, would we put that under the assessment and plan? No, because we are not medically treating that. However, that diagnosis is so important to the experiences that the patient is undergoing at this time and needs to be monitored for. This slide highlights common documentation patterns that increase audit risk and reduce clarity. even when the intent is to be thorough or compliant. One frequent issue is listing diagnoses in the assessment and plan without any associated medical decision making. This leads to vague monitoring language that does not reflect actual care and may imply interventions that are not occurring. I'm continuing to re-emphasize where notes go as far as under the HPI or if medical decision making was implemented, and this belongs under the assessment and plan. Another common trap is documenting deferred or hypothetical decisions, such as monitor to see if treatment is needed. Medical decisions are made at this visit. If no decision is made, it should not be documented as pending. Copy forward documentation from hospital notes or prior visits can also introduce inaccuracies, particularly when acute conditions have resolved or are no longer relevant to the current encounter. These snippets and documentation principles are designed to help avoid these traps by clearly separating clinical context from medical decision making and ensuring that documentation reflects what is truly happening with the patient. By avoiding these patterns, we improve note clarity, reduce audit risk, and ensure our documentation remains ethical, defensible, and aligned with CMS expectations. The purpose of this framework is to support accurate ethical documentation that reflects actual clinical care. The history of present illness is where we describe clinical context, stability, and relevance. The assessment and plan is where we document active medical decision-making. Keeping these roles clear improves clarity, consistency, and audit defensibility. Monitoring alone does not represent a medical decision. When no treatment decision is made at a visit, it is appropriate for a diagnosis to appear only in the HPI. Forcing diagnoses into the assessment and plan without a true plan increases documentation risk rather than reduce it. These standardized snippets are optional tools designed to support this distinction. They help explain why a diagnosis matters today without creating implied interventions or unnecessary plans. Ultimately, the goal is documentation that is easier to write, easier to read, easier to defend, and documentation we can stand behind clinically and ethically. This slide explains the expectations when providers receive documentation queries like the example shown. Queries often list diagnoses identified somewhere else in the medical record, such as hospital documentation, nursing notes, or prior encounters. The purpose of this query is to request clarification, not to require that every diagnosis be actively managed or placed into the assessment and plan. Providers should use independent professional judgment to determine whether each diagnosis is relevant to the current visit. If a diagnosis is relevant as clinically context or supports skilled nursing monitoring, it may be appropriately addressed in the HPI. If no active medical decision is made, it does not need to appear in the assessment and plan. It is also acceptable to respond that a diagnosis is not applicable or not addressed when it is not clinically relevant to the encounter. Queries should never result in fabrication of care. Clarification does not equal intervention. This approach ensures documentation remains accurate, ethical, and defensible in the event of an audit. So in this query form, you can see that MDS has pulled out multiple diagnoses from the history from the hospital. So for an example, this patient has type 2 diabetes, COPD, protein calorie malnutrition, chronic pancreatitis, pneumonitis, so aspiration pneumonia, and metabolic encephalopathy. So now the next statement is saying, based on your medical judgment, can you please provide a progress note? They're not asking you to address this form at all. They're asking you to write a progress note, including the appropriate diagnosis, if any, associated with the above findings. That being said, at what point would type 2 diabetes not be appropriate, or COPD not be appropriate for the nurses to monitor, or protein calorie malnutrition not be appropriate for the RD to evaluate? All of those diagnoses that they're listing there all need to be in your HPI. It's a free gift from MDS. They're saying document on this. You don't have to do an assessment and plan. They may be stable conditions, but stuff that is being evaluated by the nurses. So don't write on this sheet. Don't write things are resolved, because chronic pancreatitis, the acute pancreatitis might be resolved, but chronic is going to be chronic, and we need to be monitoring for that. Us as nurse practitioners, no intervention needs to be done, but we absolutely want to address that under the HPI. It says, please note that your response may include none or not applicable. That's rarely the case. Rarely would you have a patient with COPD that doesn't necessarily have any intervention going on right now that we wouldn't want someone to evaluate. So when you get these query forms, you can go under your HPI and you can click diabetes without treatment, COPD without treatment, protein calorie malnutrition. All that's saying is that nursing is going to continue to monitor those. As they monitor and new information comes forward, you may adjust the assessment and plan based on if new information is brought forward, and we need to address that. This presentation has focused on how the documentation we write in the history of present illness flows directly into MDS capture and audit review. Our goal is not to change clinical practice, add work, or increase documentation volume. The goal is to ensure that what we document is accurate, defensible, and ethical, and that it clearly reflects the care we are actually providing. Throughout this presentation, we discussed how to document clinical context appropriately in the HPI, how to distinguish monitoring from medical decision-making, and how to determine when a diagnosis truly belongs in the assessment and plan. While this framework is presented from the nurse practitioner documentation perspective, it is important to emphasize that provider documentation and facility documentation are part of the same clinical record and the same care process. We are documenting for the same patient, within the same organization, with a shared responsibility for accurate, cohesive, and patient-centered care. Thoughtful HPI documentation supports nursing assessment, skilled monitoring, and accurate MDS capture, just as nursing documentation informs provider assessment and medical decision-making. When documentation across disciplines is aligned, it tells a clear, truthful clinical story that supports patient care and withstands audit review. This framework supports skilled nursing documentation without inventing care, forcing plans, or documenting decisions that were not made. It aligns clinical judgment with CMS expectations and MDS logic. Ultimately, the emphasis is on clarity, honesty, and consistency so that our documentation reflects care we can stand behind professionally, supports the facility appropriately, and serves the best interest of the patient. This works when we remember that we were all documenting on one patient, one story, and one standard of care. My information is there. Reach out if you have any questions. Let me know if you need any additional snippets written, ordered, and I hope you have an amazing day.